My name's Dr. Mambodaliso, first year registrar in pediatrics and child health. I'm going to take you through the case review of a 7-year-old male with hemolytic anemia post-severe malaria infection who presented to us on the 9th of January and was with us for about 3 weeks. So, summary for the case. I think Dr. Lyra is sharing the screen. So the summary for the case, this was PG, a 7-year-old, previous well male child who presented with severe hemolytic anemia with severe malaria. The patient was found to have severe hemolytic anemia, jaundice, and AKI and black water fever with splenomegaly and the concern of paroxysmal nocturnal hemoglobinuria. So on the presenting complaint, the child presented with a 4-day history of body hotness, vomiting for 4 days, and constipation for 4 days. History of presenting illness. This was a previously well child who came with an acute onset of fevers, vomiting, and constipation consistent with an infective syndrome. There was also history of the child staying in Kaoma, which is a malaria endemic area, and he came to Lusaka, the capital city, about a month ago with a history of recurrent malaria infection whilst the patient was in Kaoma. On admission, the father gave a history that there was some history of irrelevant talking. However, there were no seizures observed, no bleeding manifestation, no history, and there was also a history of passing dark colored urine. Upon from the patient was referred from, they did the RDT at Kanyama, it came out positive, and the patient was started on Artesunate, which was later continued when the patient reached our facility. On review of system, there was no weight loss, no night sweats, no history of TB contact, no bleeding or bruising, no bone pain or lymphadenopathy symptoms. And then on the birth history and social history, there are no history of chronic illness, normal growth and development. Patient currently lives in Lusaka now with the father. The parents are divorced, and the child came to stay with the father who stays in Lusaka, which is the capital city of Zambia. And however, there were no family history of hematological disease. So on examination findings, the child was markedly pale, febrile, and well nourished, and was hemodynamically stable but tachycardic. On review of the system, CVS S1 and S2 was head and tachycardic. And on the abdomen, there was a splenomegaly of about 4 centimeters. No lymphadenopathy, no focal neurological deficit were observed. And then initial investigation from the referring facilities, they did an RDT which was positive. And upon assessment, they came up with the following differentials of hemolytic anemia, post-malaria infection with black water fever with concerns for AKI, with the following differentials of paroxysmal nocturnal hemoglobinuria, cholecystitis, and hyperactive malarial splenomegaly syndrome. So this was the blood workout when the patient had come. Patient came in with HB of 7.9 grams per deciliter with a white cell of 3.5 with a platelet count of 387 and an MCV of 7.3. That was done, which was positive, and the patient had an LT of 2.7, AST of 16.9, and an ESR of 155. And patient had a creatinine of 152 micromoles per liter with a urea and creatinine of 21.8. However, whilst the patient was being managed on the ward, went on the ward, upon doing an HB recheck, the HB was not to drop. It dropped to about 2 grams per deciliter, whilst in the ward, and the patient was transfused, received an alicot of BT. However, after receiving an alicot of BT, when we repeated the renal function test, the creatinine was raised. It was about 509. And the renal team reviewed the patient, which was being evaluated for pre-renal AKI, and which later resolved. But however, the HB kept on dropping. After being transfused, it had risen to about 5.4, but later became to 3.9, and the patient received another ARICOT, which went to 3.4. And then among the other tests we had done, we did RPR, which was negative, and we also did hepatitis B, which was also negative. And then an MPS was done, which showed no malaria parasite at the time. However, we were unable to do the bone marrow wasn't done. And then upon our refined differential diagnosis, we came up with hemolytic anemia secondary to severe malaria. And then on the hemolytic anemia diagnostic framework, there was hemoglobinuria, and then that was positive and elevated ADH, and however, we're unable to get results because our lab our lab was unable to do this, and the patient couldn't afford to do them from the outside lab. And the other investigations which were pending was the CD55, CD59, because we had consent for paroxysmal nocturnal hemoglobinuria and D-dimers. But however, our lab we couldn't run these, and the patient could not afford to do these investigations at the time. So our management plan, what we did for the patient was was continued on artesunate, received supportive blood transfusions, and was later started on methylprednisolone. And these other diagnostic investigations we are sourcing them for them to be done at the time, yes. And then our management plan, the patient became stable, and the patient was discharged, and we were following up the patient, and we have a multidisciplinary review, and also close monitoring of the patient, which we are to review this patient the next 2 weeks. So on the outcome, so the patient was admitted for 3 weeks and was clinically stable at discharge, and then is under ongoing outpatient follow-up with pending investigations. So the reflection and learning point from this case is to apply formal diagnostic criteria early. And the other challenges we had, it was lack of diagnostic resources for key tests, which could have led to some delayed or missed diagnosis. And the other key factor which was noted was about malaria prevention, and how important it is, and it's very cost effective, because for the cases other tests where they couldn't manage, this could have been avoided if we had put in more robust preventive measures to prevent the infection rather than to treat it. And then we come to our discussion questions. So did the patient meet the criteria for hemolytic anemia with concerns for PHI? The patient didn't meet the full criteria, or however, we are unable to do the other test, which could have helped us in this case to rule out paroxysmal nocturnal hemoglobinuria. And then what infection should we prioritize in Zambia? So looking at infectious, we have a lot of the high malaria burden country. So we need to invest more in the malaria preventive programs and treatment so that we prevent such complication like this, the way this child came presented to us. And then how could diagnostic delay be reduced? So diagnostic delays could be reduced if we have laboratory tests to do things like for raised LDH, to do for the CD55 and 59, so as to help us to come up with a diagnosis as early as possible, to come up with a management plan for the patient. With those few remarks, thank you very much.
Great. Thank you very much for the excellent presentation. Any comments or questions? Subarna, you've got your hand up. Go ahead.
Sorry, keep me on mute. Thank you. I'm still the presenters from London. My question to you. Yeah.
The sound is quite distorted. We can't hear.
Sorry. Can you hear me now?
It's sounding very electric, like maybe your headphones.
May I ask a question? Thank you for the presentation. Was there any specificity for IgG or C3d on the DAT?
No, because the ones we did from the NAN, there wasn't any specificity as per se on the DAT. Just indicated that positive in the ones we did.
Thank you.
Subarna, are you back?
Yes, I'm back. Thank you.
Oh, perfect.
Can you hear me?
Yes, it's perfect now. Thank you.
Thank you. Sorry about earlier. So my question was, so what was the hemoglobin at discharge? And what was the rationale for the methylprednisolone? What were we? Is that something you would normally do with quite severe AKI inducing black water fever? And what was the final diagnosis? Do we still think it's, common things being common, it's very likely to be a malaria-induced severe black water fever? And the final question is, was there very severe intravascular hemolysis and red urine? Thanks.
Oh, thank you very much for your question. So for the methylprednisolone, it was studied in view of the severe hemolysis which was there. And then you can just repeat. I didn't get your second question.
Sorry, beg your pardon. So methylpred was just a pulse? Did you just give a pulse, or is he still on prednisolone?
No, he's not on methylprednisolone.
Okay, so he's just on a pulse. Okay. And my question was, what was his discharge hemoglobin?
It was at 7.5.
Okay. So he's kind of recovered from his hemolysis altogether.
Yes.
Yes. So my question was, what was the final diagnosis? Did you feel that this is all in keeping with what you would expect a very severe case of black water fever to be? We don't see black water fever here in London, so I don't have any clinical experience of this.
Also, we see a lot of black water fever on this end. So this was in keeping with the black water fever and the severe malaria which the patient had.
Yeah, yeah. So, in terms of the rapid antigen test that you did with the malaria in the beginning, pre-artesunate, and then you did another one towards the end, post-artesunate, and the second one was negative. That would still just mean that, the antigen has been removed from the circulation. It doesn't negate the diagnosis that this is all black water fever related, right?
Yes, yes.
So why were you worrying about PNH? Was that mainly because there was intravascular hemolysis?
Intravascular, that was just our concern. Wanted just to rule it out.
Okay.
Due to the intravascular hemolysis.
It's unusual
But
in 7-year-olds, right?
yeah, it's very unusual, but it was more of pointing to the malaria and the black water fever.
Thank you.
Perfect. Any other questions or comments? Dan?
Oh, hi again. Sorry. But before treatment, or during treatment, were you able to estimate the degree of parasitemia, or did you only have the rapid test?
So we did the rapid test, and the degree of parasitemia when we did our MPS, it showed no parasites in, but our RDT was positive.
I had a question about the renal failure. So did he need any renal replacement therapy, or was it just conservatively managed and then eventually improved?
I didn't need any renal replacement therapy. It was conservatively managed, and the child improved.
Perfect. And there wasn't any other cytopenias, no low reticulocyte count. Apologies if I missed it. Just again, along the lines of thinking about PNH, was there any other reason? But it sounds like in the end, it was all more pointing towards black water fever rather than
Yeah,
aplasia
yes,
or
from our
PNH.
find, it was more pointing towards the black water fever.
Okay, perfect. Fantastic. Any other thoughts about this interesting case? Thank you for sharing it, Dr. Mambwe. Anybody wants to share their experience or any questions about this particular case? Dr. Mukoka, go ahead.
I just wanted to ask from the British team, how best you manage your hemolytic crisis, be it in a sickle cell patient or a non-sickle cell patient? What's your approach to it?
Well, I'll go first and then other people can definitely chip in. So the first priority is to identify what is the reason this patient is hemolyzing. So first confirm hemolysis by doing hemolytic screen. And then the first step is to understand, is this an immune hemolysis or a non-immune hemolysis? And if it is immune hemolysis, that helps you identify if it's warm hemolytic anemia or cold hemolytic anemia. And then you go from there by identifying the underlying cause and then treating it. So if we had suspected that this person had an immune hemolysis, say in a sickle patient, perhaps it is secondary to transfusion, a transfusion reaction, or otherwise an autoimmune hemolytic anemia, then we'll treat by immunosuppression, immunomodulation, medications like IVIG, methylprednisolone like you have given here, and then supportive therapy with transfusion if needed, especially if we're not talking about that GHTR or hyperhemolysis. In some of those cases, we try to avoid blood transfusion until we have a better idea of what we're dealing with. But if somebody has a straightforward autoimmune hemolytic anemia, they have dangerously low hemoglobin levels, we would support with red cell transfusion, and then we'd do more investigations to identify if there's an autoantibody, what is the specificity of the autoantibody, and then take it forward in terms of long-term immune suppression or immune modulation. Supportive therapy also includes folic acid and depends again on the underlying cause. And in this case, sounds like this person has intravascular hemolysis secondary to infection. So if that was the case, we try and treat the infection like you're doing with the malaria treatment. And then, of course, support the patient throughout. This is kind of just a general idea of understanding its immune hemolysis, non-immune hemolysis, and how to go forward. If somebody is hemolyzing and it's a non-immune hemolysis, we think about other things, membranopathies, enzymopathies, and see what they need in terms of transfusion support in the acute setting, and then long-term support and monitoring in the outpatient clinic, etc. So this is just kind of an outline. I wonder if other people want to also chip in terms of management of hemolysis in any patient, sickle or non-sickle. Sabana, Megan. Yeah, Sabana, go ahead.
Yeah, thanks, Summer. I was going to just suggest that maybe we could have a session maybe a session on management of hemolytic anemia in the future. I know we've got the whole year planned out now, so maybe next year. It'll be good. No, I was just going to say that, completely reiterate what you said, Sama, that it all depends on what the underlying cause for the hemolysis is, and quite a good way to start is this immune versus non-immune hemolysis. And then once you've got, or some people also think about sort of hemolysis in extrinsic versus intrinsic, meaning that intrinsic meaning something wrong with the cells themselves, meaning sickle or whatever. But I prefer to do it, immune versus non-immune hemolysis. And just having that DAT, which you guys have access to, makes a big difference. But having said that, a low positive DAT IgG is very non-specific. So again, if you have a very strong, for example, in this patient, you had a low positive, a positive DAT, but obviously this patient did not have, hemolytic anemia per se due to an immune result. Perhaps there was a component of immune response, but I mean, the main thing was that, malaria infection causing hemolysis. So just, that often, to me, in my own mind, just having that, immune versus non-immune is really helpful. And then in somebody, the question was asked about sort of sickle hemolysis as well. And it's true that when people come in with a known diagnosis of sickle cell anemia, but come in with what would be a hemolytic crisis, they do have, and this is in absence of any previous history of transfusion or anything like that, somebody could simply come in with very low hemoglobin because they are hemolyzing. And that hemolysis can be triggered through infection, through a vaso-occlusive crisis event, etc. And again, that the treatment for that would be completely supportive. And if they've got good reticulocytes, or if the blood film shows there is polychromasia on the blood film, I wouldn't even transfuse them if they are not sort of, very, very severely anemic. So yeah, that's all I have to add. Thank you.
Thank you so much. I think one of the challenges that we face on our end is that it takes forever sometimes to get a Coombs test. So it's a bit hard for us to know if it's an immune or non-immune related hemolysis that's happening.
Yeah, that will be very challenging, to not have a Coombs test is going to be challenging. Yeah. In some ways, even having a blood film, I know that the blood film was looked at in this case, just looking at a blood film under the microscope with a normal stain, it's MGG, right? Stain, or whatever stain you have access to. GIMSA, I think, is the one that's used in your lab, if I'm not mistaken. And or having a malaria prep, that might help. And having just looking at a blood film and just seeing masses of spherocytes, or seeing, for example, G6PD related oxidative hemolysis and all that, and you'll see that in many of your patients, I'm sure, as we do here. So I think we can't maybe underestimate the power of a blood film examination in the context of not having access to DAT. Although having said that, ultimately, if you've got hemolysis, you'll have spherocytes, and you can't tell whether the spherocytes are due to immune related or non-immune related. So yeah, it's quite challenging. But equally, if you have barn door malaria and the child is hemolyzing with a bit of splenomegaly and dark urine, what the most likely diagnosis is.
I suppose also at the end of the day, if you're at the bedside and a patient has a rapidly deteriorating hemoglobin and you're not sure what the reason is, this patient should have a transfusion. So I think nobody should suffer because of the lack of transfusion until you figure out what's going on. So patient has a profoundly low hemoglobin. Supportive therapy is important. Give some folic acid and try and figure out with a good history taking with simple techniques like Subarna saying, blood film, the simple blood test that you have access to, and then escalate gradually as able to more specific investigations. It's just the crux of it, I think. Okay, Fatima, you have your hand up. Go ahead.
Yeah, thank you so much. So I just wanted to add on. I think we saw the trend of the full blood count for the patient just shortly after she was transfused, that the HB kept on dropping. So I think that also made it worse because we're suspecting that there was a hemolysis, immune mediated, so that made it worse. The way you've said that sometimes we can, with a good history and other supportive measures like folic, while we're trying to determine what could be causing this. Yeah, so I have a question. You mentioned earlier that we can do a blood smear. In this patient, what do you think we could have been looking at in the blood smear, apart from the malaria parasites?
The classic features of hemolysis in a blood film are what we call polychromasia. So there'll be some cells that are more red in color, others more blue in color, and we think that's because of the reticulocytosis that comes with hemolysis. And like Subarna mentioned, there will be something called microspherocytes or spherocytes. That's another marker of hemolysis. That means the red cells are being broken down very quickly, and some of the non-perfect red cells are being pushed out to the peripheral blood. And then you might see hypochromasia because there's it's an overall anemia. So these are the main things: polychromasia, microspherocytes, reticulocytes, and then of course, because your case has malaria, you'll see the intracellular inclusion malaria parasites. Overall, these are the things you look for, and that makes you think that this person has active hemolysis. Obviously, if it was a sickle cell patient, you will see increased sickling, target cells, other markers of that this patient has some sickle going on. And if you have a big spleen, like your patient did, perhaps not in the acute setting only, but if you have a big spleen, you can sometimes see features of hyposplenism in the blood film, like some echinocytes, which are spiky red cells, or Howell-Jolly bodies. Yeah, so these are all indicative of a long-standing hyposplenism state that can give you some ideas on the underlying pathology, especially if you don't have access to readily have access to specialist testing. Yeah, I concur with everybody. That's extremely helpful to see a blood film in these cases. Perfect. Any other questions or comments? I think it was a very interesting case and really highlights the multifaceted approach to a complex hematological patient. I mean, it's not hematological per se, but definitely hematology factors in with the cytopenias and the hemolysis for sure. Yes, Dr. Mukoka, and then I don't know the name, but Google Pixel can go next. So, Leila, you go first.
Oh, I think Google Pixel. Let Google Pixel go first because I was thinking about the clock. I wanted to give an update on a patient we reviewed during the December MDT.
Perfect. So Google Pixel, please introduce yourself and go ahead.
Good afternoon, everyone. I'm Dr. Namunga from Arthur Davison Children's Hospital. So I wanted to find out, like, from every one of us who have managed the different types of hemolytic anemias, like in cases of situations where you don't have methylprednisolone, can we use dexamethasone or prednisolone, or what's your take on that one? In situations where we don't have methylprednisolone, what can we use?
In our guidelines, the first line for autoimmune hemolytic anemia is actually oral prednisolone, especially if you're not in a massive hurry. So we do that for 21 days, assess response, and then move on to other therapies. But I think in such a setting, my opinion is that use what is available to you. So don't delay. So if you have a rapidly hemolyzing patient, especially if you think this is a reaction or they need rapid response, I think methylpred sounds sensible. If you don't have it, use the next best thing, whatever you have available, oral prednisolone or even dexamethasone. Dexamethasone is just quite potent, and I'm keen to hear what other people think. But I've used it in one of our long-standing autoimmune hemolytic anemia, and they did end up having quite significant steroid-induced side effects, and renal insufficiency, etc., just because of how potent it is. But I would think use what you have available. If you're in a hurry, IV methylpred works very quickly. If you have time and you think this is an autoimmune hemolytic anemia, oral prednisolone sounds that's what we would do here.
Thank you.
Any other comments about utilization of different types of steroids and hemolysis before we move on to Dr. Mokoka?
No, I agree with you, Sama, that you use whatever you have, and there's very clearly available equivalent dosing, versus various types of steroids. So, whatever you would have given with methylpred, you give the equivalents in whatever you have.
Lovely. Thank you very much. Okay. Any other questions about this particular case before we move on to the update from Dr. Mokoka about a previous patient? Perfect. So I think that's an old hand from the last commenter, but Dr. Mokoka, go ahead, please.
Yes, so in December, we had presented a case of a female adolescent, if I'm not mistaken, who we were thinking could have had warm hemolytic anemia. We're entertaining the thought of Evans syndrome. And I think at the time we presented the case, we didn't have the tryphin results from the bone marrow. So I think we only had aspirate, which showed a hypercellular bone marrow. So the tryphin results came out a few weeks later, and turns out she actually had an acute lymphoblastic leukemia. And she actually returned, I think, 2 weeks or so later with an HP of about 1, even had, I think, a stroke. Somehow ended up in ICU. And I think, unfortunately, she died. Yeah. Because I think the time we presented, we didn't have the tryphin results.
I'm so sorry to hear that.
Yeah.
Sorry to hear she had a bad outcome. Lena, remind me, she was presented as hemolytic anemia, question
Yes.
Evans.
Mm-hmm.
Okay. And there
Because
was nothing on the film at that time in the way of blasts or anything. Presumably not.
No, I think they were not blast. It was more of the BMA that was done. They didn't present. The blood smear just showed spherocytes with loss of central pallor and polychromatophilic cells, but they didn't comment on the blast cells.
And the
And
bone
then the
marrow
BMA,
aspirate. Yeah.
the bone marrow aspirate just showed a hypercellular bone marrow with increased number of immature red blood cells, abnormal developed red blood cells. They showed some lymphoid aggregates or infiltrates, which were noted to be present. And they also noted some mild reticulin fibrosis grade 1.
Yeah, it's quite challenging because you think that at least a bone marrow aspirate, would be more informative than a peripheral blood film in these cases, and she did have one. So I'm wondering, did you have anything on the Trifine in the way of percentage of the ALL cells or anything like that? Any quantification?
I can't quite remember the full detail of the tryphin report, but I just noted the leukemia.
Yeah, it is quite sad and unfortunate. Despite she did have most of the investigations that could have had been done, except perhaps a flow sample on the marrow and the peripheral blood that would have come back faster. But it is unfortunate.
Well, actually opened the peripheral blood smear. It actually said no blast seen on scanning.
Yes, but that's sometimes that happens. You'd have a marrow packed with blast, but nothing on the peripheral film.
Mm.
So but I'm surprised that the aspirate on the bone marrow did not show any blasts at all. Sounds like it was just morphology, which we know probably is what is available. Just looking at the aspirate with morphology, and then the trephine perhaps had done a more detailed look, or even immunohistochemistry staining that revealed the ALL cells. But it's something that perhaps if we did have an aspirate sample sent for immunophenotyping, it would have been picked up. But it sounds like that was not done. Is that right?
And it wasn't done.
Mm-hmm. And remind me, I'm so sorry. I do not remember the details of this case when it was presented, but she did have other things such as B symptoms, bone pains, anything else, hepatosplenomegaly, anything suggestive of a hematological malignancy?
Let me just open up her details. History. So no, she didn't have any bone pain, but had base symptoms. She had body weakness. She had a fever. She had abdominal pains though, but no bone pain. And on her physical exam, she had hepatomegaly. And then no lymph nodes that were actually noted. Because initially she was thought to have a viral hepatitis. Then she returned with recurrent hemoglobin drop despite receiving blood.
Yes, thank you. Yeah, I think it's just very difficult, isn't it? And it's good learning so that perhaps in these situations we have to have a much higher index of suspicion of hematological malignancy and try and dig a bit deeper. But although I understand the restrictions in terms of testing. But thank you for sharing and thank you for feeding back. And I'm sorry she had a poor outcome. Does anyone want to comment on this case or what could have been done differently or any kind of good learning points? Perfect. I cannot see any hands up. So thank you, Leila, for feeding back. And if nobody has any further comments, may I ask you all to give us some feedback? Asia's just put the link in the chat. We would like to hear from you how you think these sessions are going. What sessions would you like to see in the future? And what cases we have already agreed a schedule and some topics until December. Mostly around pediatric hemato-oncology, sickle cell disease, and a little bit of general hematology as well. Next month, in March, Dr. Josh Wright is going to be presenting about the chronic pain in sickle cell disease. So please do join our talk, and we will continue to review your feedback to make this session better and better every time.